everyone. So we had a lovely morning at the airport, and unfortunately didn't actually make it to you successfully, but I think we're doing a pretty good alternate considering Rochester and Boston are not so close to each other. We couldn't just hop in the car. So welcome. We're still going to make this a workshop, as you guys can see. Brenda and Luce have done a wonderful job planning this last minute strategy. So I would like to just take a minute to thank them for being not only flexible and incredibly competent, but also good-natured about all of this. So you're very lucky to have them working with you. Nitzali and I are going to speak a little bit about our experience and about how to build and maintain, with a focus on maintain, high-functioning teams. And you'll hear our story, so I won't preempt it too much. So today, our goals for our time together are to have you really do a deep dive with us on an experienced high-functioning team care model at the Cambridge Health Alliance, and in particular at the Union Square Family Health Center clinic. Then we actually turn the focus to you, and we want you to spend time developing concrete plans within your clinical environments for how to extend your team care if you're already working in team care, create and build high-functioning teams if you've not yet started on that journey, and learn from each other as well in this process, because I'm sure there are experts already in the room. And then our last objective is to hopefully inspire everyone to use what they've heard and learned and worked on today to go back to their clinical environments and put this on the ground for your teams and your patients. Because it has genuinely resulted in a happy, productive environment for all of our folks at Union Square since 2005. So we're here as part of TCPI, and I think folks have heard what this is and know what it is because you're actively engaged in working with Brenda and Luce and the rest of the team, who I didn't get to meet, but will someday. These are the aims, and really the goal for all of us is to move the healthcare system from an interaction where you have to bring a patient in for a visit to get any kind of advance of care for them and payment, to an environment that is much more rewarding, where you simply are tasked with taking the best possible care of your patients, and they get to actually take care of you as well in this process. And the whole clinical environment becomes more focused on health and less focused on being overwhelmed, quite frankly. This is the phase 1 milestone. I'm guessing you guys have rocketed past, and then you should be into phase 2. I didn't have a nice phase 2 slide, so I put this in just to remind us that we've already been on a journey together, that we're already got the vision, and that we're going to really start working at what I call brass tacks, right? Get down to where we're really getting the flooring in. We've got the subfloor, which is phase 1, and we're starting to really build our medical home. So designing teams to fit the work, right? Who are you? Really, if you use data to drive change, and that is part of one of the fundamentals of medical home transformation, you have to analyze who you are and the work you're trying to do first. So we are speaking to you from the Cambridge Health Alliance, which is an academic, public health, safety net system that is just north of Boston. And if you look at those 3 components, they're each a really fabulous way to not get paid in the old system. And we're really good at not getting paid in the old system. So we had a very high level of motivation to change. So one of the gifts we've been unintentionally or otherwise given by the move to value-based care, and we'll talk more about what the definition of that is in our time together. One of our motivations was that we actually tried to do this when it wasn't financially sound, and built services and teams and a clinical and cultural environment that fed that move to value before it really was a good idea financially. And we got lucky and are now leaders in this because we took a chance, and I'm happy we're still around, and I'm even more happy that what we built is actually worth doing every day. And Nitzali and I still work at Union Square and see patients every day, and I actually am half-time clinical, and I am living the dream literally, because what inspired me to become a leader in medical home transformation was the desire to stay a family doctor and not have to give it up and not burn myself out. So you can feel free to ask me very detailed, excruciating questions from the provider perspective, and you can do exactly that kind of thing with Nitzali, because while we were at the airport this morning, we were both sending emails about flu vaccine. So, which we're starting on Monday. So that's a little bit about the background financially we come from. We are what is a sort of public system in the US, as you all understand how our healthcare system works. We see everybody, so we have some private pay patients, but we are predominantly a Medicaid-based system. So we have really interesting, wonderful patients. They are largely come from other countries because Boston is a gateway city. And we have an increasing number of patients and primary care visits. We're going up to 120,000 patients across the system this year. So I'm going to turn it over to Nitzali to talk a little bit about the Union Square Family Health Center journey.
Hey guys, so as she says, my name is Nitzali Rivera, and I know I have to speak very slowly because of the sound over there, and plus my accent, so please bear with me. So I started in Union Square in around 2002, so it's been almost 15 years that I've been with this site, which I have loved to be. We started the medical home transformation in 2005, mainly focusing in diabetes, patients with diabetes. I used to be Dr. Meisinger's medical assistant. And in 2008, we were a learning collaborative, which we were sent out to show and to speak about how we were taking care of our patients, because we were doing an enormous change with our diabetes population. So we wanted to share outside in other areas. Then in one of the conferences, I was actually called to be part of the NSA, the National Advisory Committee, for the Learning for an Effective Ambulatory Practices project. That was we worked together with the Robert Wood Johnson Foundation, and it was kind of to put something together to introduce medical home into other sites within the whole United States. So it was an amazing journey as being part of that project. And I wasn't really up to choose. We were supposed to choose up to 30 sites within the whole United States, which was a huge and amazing decision that they have to come up with for the research. And I couldn't be part of mentioning Union Square because I was part of it, of course. But it was put into the list, which I was really excited. And we actually got to be part of those 30 centers that were researched what we were doing as a medical home, what we were doing for patient care. And from there, we visited so many sites, New York, Washington, different states, to research them, to see what they were doing with different titles, how they were, the workflow that they were using, what were they doing differently that other sites were not doing, and that was improving patient care tremendously. So we were really excited to be part of this, especially me being part of that national committee, which I never thought that I was going to get to, being a medical assistant, to be honest with you. Once I went into that room full of doctors and very important people, I was in shock, to be honest, but it was an amazing experience, and I learned a lot from being part of that. And what I was going to say, I mean, Union Square have gone really far, and I'm really proud of being part of it.
Nitsi, talk a little bit about your journey before medical home transformation at our site, and what it felt like as a medical assistant before and after.
Oh yeah, no, absolutely. So as being a medical assistant since 2002 at Union Square, it got to the point that it became a really boring work for me. Just bringing in the patients, just taking the vital signs, bringing them into the exam room, and that's it. The doctor will be right here, and just leaving them there, just waiting. It got to a point that it wasn't interesting to me anymore, and I did brought it up to Dr. Meisinger and Dr. Wheeler, who was the medical director there at that time. Once we started doing the medical home transformation, Dr. Meisinger talked to me about it. I was her medical assistant, and she just started teaching me little by little. She just started kind of huddling with me in the mornings, and going through her list of patients for the morning session, telling me what to do. We should do this with this patient. We should do that for the other patient. In other words, she was training me little by little, and it was an amazing path, because I do have to say that training and that leadership that she gave me to use, and got me to where I am today, which I'm a nurse now. It's just got me so interested that I just kept asking her questions, and I was able to do, she was letting me do more and more for patients. For example, I used to bring in the patient. She asked me to get a history of why they were there for the day. I used to go back to her, let her know the patient's here for so-and-so. This is the complaints for how many days. And she used to just ask me, what do you think it is? You tell me. What should I do with the patient? So I was in shock that day, because I was like, what are you talking about? You're the provider, not me. But it was amazing, because it gave me the opportunity to think, to improvise what she was teaching me, and that gave me a pathway to learning, to be more interested, to motivate me to do more for the patients. So, and this day, we are able to, as a medical assistant, they are able now to just bring in the patient, get a history, if they're, because of our computer system, if they're due for anything other than just a visit for a cold, for a mammogram, a pap, a colonoscopy, they need fecal calls, everything, we get it done right there and then, before even the provider gets into the room. So in other words, the patients had everything, every appointment booked, everything they needed. Once the provider came in, they just have to just deal with the complaint of that day, and that was it. So it makes the patient happy, it makes the provider happy, and it makes the workflow better. So it was a huge difference from the before and after. Since I've been with them for about 15 years now, I saw the difference from the before and now. And I don't only love it, but our patients love it. They always come to me and tell me how great of a job we're doing, meaning they really feel that we care for them, that we're really doing, that we're really taking care of their health, that we really worry about them. We have patients thanking me for reminding them of what they need to have done, because with their busy life here in Boston, and I'm pretty sure everywhere else that they have outside of their home, it's not easy for them to remember to come in for a physical, to come in for a PEP or mammo or colon. But that's why we're here for them now, and so they really appreciate that.
So our patients are full spectrum family medicine. We have a relatively young population because we do a lot of immigrant health, and we mostly don't speak English, although we can all speak English. But I deliver care in usually Portuguese and Spanish and Hindi and Nepali. So we do have interpreters. Many of us have learned the languages and have become culturally competent in the cultures that we care for, partly because we have amazing team members like Nitzali helping to teach us about the populations that we serve. And I know that is a strategy used by many different, particularly FQHCs, but also community health centers all over the country. It allows in the team context for a very powerful bi-directional learning that we'll explore a little bit more. Why teams, right? This is part of the bi-directional learning. Diverse team members actually really are an important part of taking care of a diverse population. One of the things that we have realized as our journey at Union Square and at Cambridge Health Alliance is that patients will fall in love with a particular team member. And we want to actually encourage that relationship, but we want to make sure that it is done with the appropriate level of training for each team member so that the patient continues to get the best possible care. So what we have done is we've created a team environment where we have many points of contact between team members so that when patients are telling different things to different people on the team, there's a place for us to come back and actually gather that information and make sure it's coordinated care. And we'll talk about how to do that further on. This is actually the roadmap for how you do practice transformation. This is the Safety Net Medical Home Initiative evidence-based study that we were part of, and that was how Robert Wood Johnson learned about Nitzali and decided to make her a board member, which I think is fabulous because she's clearly fabulous. The order is actually quite important for transformation in the United States. So please respect the order. Engaged leadership is really fundamental. So if you're here, so I feel like that you check, you've got that one, right? We're going to talk a little bit about a quality improvement strategy in the context of teams. It's really essential that this be in place because this is more than just having a report or a registry. This is actually a culture change where everybody in the health center or in the clinical environment starts to ask questions in a different way. And it's also a profound way to allow for a flattening of the hierarchy, which is so essential in team, because anybody can ask a better question than anybody else when you allow that to grow. And that is really the essence of quality improvement. Empanelment, I think, is really not the sexiest step in this staircase. And really, I think people tend to fall asleep. But it's fundamental, actually, and I'm a big fan of boring people with a little attention to it, because if you don't have division of the work, if I'm getting my patients mixed up with another doctor's patient, then I very quickly disengage because I'm back to overwhelmed and I don't really care about the other doctor's patients. I might pretend I care about their patients, but I don't really care about their patients. I care about my patients. So keeping that clean is really important to keeping providers engaged. And it's really fundamentally the work of reception and operations and the team, so that when you're defining who belongs to which team, there are clear rules, patients are aware and give their consent, and all the operations then become centered around those smaller teams. And that is one of the essential elements to maintaining this work. The sustainability of this work is very dependent on impaneling. Only then can we really start to talk about what we're supposed to talk about today, which is team. And so we took a little time as part of our discussion today to go over the steps that I don't think you can entirely take for granted in this process, because as you'll hear as we tell stories about the work that we're currently doing, you go back constantly and have to make sure that you've got things in place and then move forward again. We know who we are. We know there's a map, right? Now, let's define the work. This is what primary care has been asked to do, right? We have been actually asked to take a system that was really set up for urgent care and now manage chronic disease in that system. So as the locus of control in healthcare has changed from the practitioner, right, and the antibiotic shot that's going to save your life, to how do you eat every day? How do you exercise every day? How do you take care of yourself, right, human being, patient, every day? The system really hasn't caught up. And that is fundamentally the underpinning of why medical home transformation and teams are an essential part of care for the future. Chronic disease is not going away, and it's literally impossible, next slide, to do this work in a 15-minute visit. So this is a study that showed that. Always nice to document, but certainly everyone in the room knows that this has not been going well for a very long time. So we know the work we have to do, and we know that the system is not supporting the work, right? And we also know that there are people around that are trying to help, but are actually not set up in a system that's going to get us there. So let's talk a little bit about how are we going to do the work? Who is around to do the work? I'm going to turn it back over to Nitzali for this, right? And we're going to go back into discussing teams.
So how did we learn that teams do a better work than than doing the work individually? When we started dividing the teams, we noticed the difference that the not only workflows were better, but we were not only the patients were teaching us, we were learning a lot more about patients. The patients were learning more about us as individuals. We were learning from providers, but providers were also learning from us. So I think that was one of the keys that really helped to introduce the teamwork and how it improved the work that we needed to do together for that patient care. For example, we divided the teams into provider, to one RN, one medical assistant, and to a receptionist. That was one team. Let's say Dr. Meisinger's team. One receptionist, one nurse, one RN, Dr. Meisinger, and her medical assistant, which was me. So once these patients started seeing that we were working, I was working as Dr. Meisinger's medical assistant, that Nidia, for example, is Dr. Meisinger's receptionist, and that Amberly is Dr. Meisinger's registered nurse, they started getting to know us better as much as we were getting to know them better. And when they started calling and knowing that and getting used to the fact that we were working as a team with Dr. Meisinger, they even started calling and asking for media to speak directly regarding appointments or regarding anything the front desk end needed to be responsible for when it comes to Dr. Meisinger. Or if they needed anything, they will call for me directly. Oh, can I speak to Nitzali, Dr. Meisinger's medical assistant? And I will call them back and help them in anything that I could help them with. Or if it was something, you know, that only the RN could take care of, they already knew to ask for Ambly. So, you know, they started getting to know us so well as a team, and they knew that we were going to get things done for them.
And the thing that went away that is really important for providers to hear, if I'm assuming there's some providers in the room, is those messages that said, patient called, only wants to speak to Dr. Meisinger. Those disappeared, gone overnight. It was fabulous. Because for providers, when you get that message at the end of a busy day, you're exhausted, you already have a list of people you have to call and sometimes give bad news to, so you're already dreading the phone call section of your day anyway. You really would prefer to be home with your family at that point. And you have these often questions about, I need a referral, or how do I sign up for the patient portal, that you know really did not have to come to you. So allowing patients to explore using other team members and having those team members consistently every single time help them is part of the magic of how you can unload the bottleneck, which is the provider, and we'll get to that in a little more detail. Now let's actually tell a little geeky story about how Nitzali and I have been working to change the role of nursing by introducing this new LPN role into the clinic quickly. And we'll actually use this as a theme as we go through teams and putting in high functioning teams today.
So when I became an LPN, I was transferred from Union Square into another site because there was no space at Union Square. But thank God I was saved by the bell, by Dr. Meisinger, by grabbing me back when there is an LPN position available at Union Square, which was very excited to come back home, because that's how I call it. I call it my home. And so at the beginning, because we are a huge organization, CHA is a huge organization, when they decided to start hiring LPNs, they just decided to hire LPNs just with a very narrow role, which was, you know, vaccinations, to give the RN more freedom to take over and expand their role, the license. So Dr. Meisinger and I have been like trying to put something together where not only the RN license get expanded and the role get expanded, but also the LPN, because the LPN come to see can do everything the RN can do, at least here in the state of Massachusetts. So we've been trying to get leadership together to expand the role of the LPN, but also focusing on, if we're going to expand the role of the RN, it's to expand it focusing on patient education, which we know is going to impact all the chronic diseases that, you know, the patients that we take care of. So we have been trying that since March, and you know, leadership has been really busy trying to put us together to talk about this and put a workflow and to see how it's going to work to give us more work of the RN role, so we can try it and see how it works. What else do you want to do?
So part of why we're telling you the story is, you know, we had the vision back in 2008, actually, that we wanted RNs to focus on chronic disease management, because that's what our patients have, and that's the thing that we're actually still not doing as well as we would like. Our quality metrics are really wonderful, actually, for the patient population we serve, but we know we can do better. And you have a list of human beings in front of you every week that you are reviewing when you work in the medical home environment that you know you can do better for. Now, the process then of trying to get LPNs introduced is very similar to the process of starting a new team. You have to define the roles. The role came to us predefined in a way that really didn't offload the RNs terrifically, because the RNs were still doing tasks that probably the receptionists should have been doing. So handing those to another nurse didn't seem to make any sense. But then changing all of the roles simultaneously is actually a lot of work, and as you all know, because you're doing that. So it takes a while, is the message. We started, Nitzali's been back at the site as an LPN now for two years. And really in March, she and I sat down and said, okay, we're fed up, we're just doing this ourselves, wrote stuff down. But not until August did we actually get sort of buy-in from everybody at the clinic and the leadership. We had a new nurse manager. Finally, we decided to sit down last month. We sat down, we wrote everything up, and we put in, this is very important, we put in a date to review the plan, right? August is August. Some people were missing. Come this Wednesday, which is exactly what we just did during our nurse provider meeting on Wednesday, we actually hadn't done hardly any of the things that we said we were, but that's okay because we had put in the review date. So we updated the review date, we updated the list, we had now everybody present because everyone's back in September. And now we really are going to do it, and we're going to review it again in October. So patience is the point of this slide, right? It takes a while. Keep the vision in place, keep leadership focused as much as they can, and understand that it takes time, and be kind to yourselves as part of this process. So, yep.
I totally agree when it comes to leadership. One of our biggest experience with leadership is that they have been really involved in getting us involved in every single change that they decide to make. As you heard her saying, we are always in the meetings together to decide what changes are going to happen, when they're going to happen, when are we going to review them again. So, you know, they have really, staff being involved in all these changes have really motivated us to continue doing the work that we do, because we want to see it work. And we'll do whatever it takes to make it work. And we all know, and we're used to it, that it just takes time, and we just keep being patient. But at the end, we get the reward.
And the funny reward, and I think Nitzali said this without really explicitly saying it, is that actually you're certainly not bored anymore. Nope. We're on the busy side. We've solved the boredom problem pretty successfully. We're now in the psychotically busy category, but the boredom problem is gone. So that is actually a very powerful thing. When you have everybody that's rowing right together, the boat just moves a lot more quickly. Our boat is rocketing down the river now because we have receptionists, medical assistants, right, patients, we have and all of nursing and providers headed in the same direction. So we actually have patients on our care teams, and I wanted to say that very explicitly. So we try to have two. We actually have a workflow team that really has two patients on it and meets twice a month and reviews everything that we send out to patients ahead of time and all of the workflows, because we learned that if you don't want to redo work that you've just done, show it to your patient partners and then engage with disseminating it. They always have a perspective that you don't have, and they always remember something that either you forgot or you did really in a way that's not as powerful as what they can help you get to. So if you haven't got patients and patient partners, I highly recommend that you do that, and I'm happy to help any group via Brenda and Moose and your PTN with I think really good tools for how to choose patients. It's very important to choose the right person, and we'll talk today about how to set up structures within which you can actually start to use them as partners. So this is a schema that really shows what we grew up in together, right? This is actually what we were all raised in, and this is the cultural soup that we have actually all been eating all this time. And it's important, I think, to look at it and digest it and understand. It's also how we have gotten paid. It is also what the workflow, when you have to bring everybody in for a visit, results in. And the big circle at the middle is the bottleneck and is traditionally the provider. The system has really, I think, gotten explained both to us and to others as a provider or doctor-centered system. But if that were true in primary care, then we would be full of primary care doctors and doctors would be fabulously happy. So it's not really a doctor-centered system as much as it's a payment-centered system, and the doctor happens to be the only person in the health center that can generate a bill. This has got all sorts of consequences that I know everyone is aware of, but it was useful to us to actually write it down and understand that even though the team is present in this diagram, they're not focused on the patient, right? They're not focused on the work. They're focused on generating a bill. This is what Nitzali and I have been building with our teams at Cambridge Health Alliance now since 2005. And it's a much more efficient, much more patient-centered workflow. And it's actually kind of hard to find the provider in this slide. I'm there, but you have to find me. So this is a good visual representation for me of how I am a member of a team, and really the only person that matters in this is the patient.
Mm-hmm.
So are there questions before we go too much further?
There's another question, Dr. Canario.
I was just curious, if you talking about leadership, buy-in and everything. I've heard all this before from, having done the cohorts and everything.
Yeah.
From one side. Now that I'm on the other side, where I'm a part of that leadership, I want to know how much leadership is clinical and how much is not clinical, as far as, for them to have them buy in from, finance and from operations and from even higher ups. How much of them are actually clinical as opposed to making this a business? Because working this as a provider is great. I would love to have a team that does, a lot of things for me and all that. But then, once again, we're still in a fee for paper performance versus value-based. How do they get the buy-in from their leadership?
Okay. Dr. Meisinger, did you hear the question, or do you need me to rephrase it?
I think let me take a stab at it, and then if he starts to wave his hands around, let me know that if I'm getting it wrong.
Okay.
Because I can't actually see who's talking either. Sorry, guys. So this, if you could go back to the two previous slides, actually. Yeah, there. So this is actually a very inefficient system. So in a fee-for-service model, this actually results in a delay. And I think one example that feels very familiar to me is when I am asked to call a patient at the end of the day and I had some no-shows and all they really wanted was an appointment that day, but they don't have the trust of the team. So I find that out at 6:30 at night when I could have seen them that day, and usually they wind up going to the emergency room because they don't want to then wait until the next day for an appointment. That's lost revenue in fee-for-service. So if you go to the next slide, please. Even though this is actually facilitated with value-based payments, it is still a better, more efficient system in fee-for-service because you can greatly increase your revenue from provider visits, from nurse visits, from pharmacy and extended team visits, and you can also increase the productivity of each visit very easily so that essentially everything is a level 4 and there are no level 2s. Now, a lot of people have become very facile at making fee-for-service lucrative, and those places may or may not get benefit from increased visits if they're already seeing upwards of 30 patients a day. But what happens when you do that, when you flog a system like fee-for-service, is people get exhausted and they burn out. And turnover is incredibly expensive. The estimates are that a single provider turnover is upwards of $1 million in revenue for a system. So there's a penny wise and pound foolishness to making fee-for-service work too well. But this system still can usually generate some increased revenue to be spent back on the team and increasing the quality of care, even in a fee-for-service environment. And I can say that with confidence because I had to do that. And in fact, when it was tiring and we had turnover and lost a fair number of providers and now have less tired, newer providers who are working in a system that does not seem designed to burn them out. How did I do?
You said okay.
Thank you. All right, let's keep going because I'd love to get to you guys and your work. This slide is really just to remind everyone that providers and medical folks are rule followers, but that there is not one rule for this. There is not a worksheet I can hand you with a simple diagram on it, and you go back to your clinic and you simply follow those steps like the gram stain, and boom, you have a medical home. This is a complex system change. So you are going to have to change the culture. You are going to have to do things over time and iteratively, and you are going to have to figure out how to love PDSA cycles, because that is the only logical way to make change, is to plan it and to measure it, to reevaluate it, just as we did in August and September with our LPN RN change, right? And yet there's absolutely no way to do this without failing. So that's the good news. We already told, I think, a bit of the story about how we develop teams at Union Square. I would just add to Nitzali's story of how we've solved her boredom problem, that really we started out without the receptionists on the team, and that was a big mistake. That receptionists, because of empanelment, because they are the face of your clinic, and because patients need to trust them to be able to have efficient care by the team, really have to be part of your core team. And so I put this in to remind myself to say that, because it was a mistake we made that I would love other people not to make. But Sally, do you have anything to add?
I do. I totally agree with Dr. Meisinger. When it comes to the receptionist, remember, they're the first person that the patient sees. They're there, most of the time. They get familiar with them. Sometimes when the providers are running behind and they have to wait so long to be seen, they always come up and check in with them again, but they always chat with them. Sometimes they spend more time talking to the receptionist than they do talking to the provider themselves. So sometimes the receptionist even know a lot more about the patient that the provider can, just because of talking to them for like half an hour because the provider was running behind. For example, when we have our planned care meetings, which we'll be talking about that soon, we go through lists, and I haven't been able to get in touch with this patient. I don't know how to get in touch with this patient. And here comes the receptionist and say, oh yes, I know this patient. She actually changed her number. She actually gave it to me, or I have to be honest with you, social media is growing so much. Oh yes, I have her on Facebook. I'll have her call the office and book an appointment. Or I've seen her on Instagram. I'll send her a message. They become family to them, and so they really are part of the team. So those patients that we haven't been getting in touch with, the front desk know them better, and they get in touch with them. So that's just examples of how we have been able to help patients through them.
And if you don't have social media set up for your site, I would actually recommend really thinking about it, because we're all caring for generations that are physically attached to their phones, and they can teach us a lot, actually, if we pay attention. We have learned a huge amount from our communities that don't use phone numbers, that use WhatsApp and use texting, because it's more efficient to speak to their home country when they're here. And that has actually transformed the way that we do outreach and talk to people, and it's a much more efficient way to actually take care of folks. So, and we can get into details with that with questions later if you're interested. So here's something I think is underemphasized, and this is one of the big things that we really feel has facilitated our sustainability. There are two parts to teams. There's a lot of attention being paid now to huddling, and I think that's wonderful, but that is essentially a visit-based model, right? Huddling is the work of the day. You plan what you're going to do with your patients who are on your schedule today. And that is very important. It's called InReach, and that is what Nitzali outlined earlier, where a patient comes in for a cold and they wind up with a mammogram and an IFOB kit and all sort of, and a patient portal sign-on and all sorts of a depression screen. Wonderful things are happening automatically now that I know deliver better care. However, that is not the only interaction of team that's going to get you to high-functioning teams. You actually need to make time for the team to meet as a team, to review the processes, and most important for population health and P for P, which is pay for performance for people who are not payment geeks. You need to then engage with registries in a process called outreach, where you need to have the team, and I say this quite strongly, not a central outreach person, the team managing part of the population health of your patient panels. And the reason you want to do it with the same people who are seeing the patients in clinic is that you're only going to get a certain number of patients to buy in to someone on the phone who says that they're from Dr. Meisinger's office, but you've never met them and you don't really know that. Some people are trusting and have lives that allow them to do those things. Many people need that relationship to actually bring them to get a mammogram and to bring them to get the colonoscopy.
Trust.
The trust, as Nitzali just said. So having the team function and the team meetings different from the huddle is something we're going to help you design today, because that is definitely the secret sauce that we have found in our Cambridge Health Alliance experience as well, particularly the Union Square experience. Without that time, you neither get enough focus to slow down and think about how things are working, so you don't maintain your cultural shifts to quality improvement, but you also don't get the value in the care that you could, because often it's the sickest patients that don't come in for care, and you have to go find them. And when you do that, when you do what I call telemarketing medicine, which is pleasant relentlessness, which Nitzali is a personal expert in, and I will make her give you her little sing-song, right, message that she used to leave on all of our patients' phones. When you have that kind of attention, people really respond, and they respond well. You do get the occasional person who asks you to stop calling because you're driving them crazy, and then you simply make a note of that and stop calling them. But largely, the 99% of people actually feel like you actually care, and you do. But you always have. You just haven't been able to communicate it well. So this is something that I think is underemphasized now, and I would love to have people really embrace in addition to the huddle. This is the series of slides, Luce. The next one coming should probably be in presentation mode, right? This is a nice not to scale diagram of how to break down the work of a visit, right? And the work between visits. So this has the first three little boxes here are the InReach, and the one box that's the remaining on the right that says between visit is the outreach. So understand that the pre-visit, visit, and post-visit boxes are actually all of what, 30 minutes per patient per day? And the between visit is the rest of your life. Mm-hmm. So it's definitely not to scale. But we pay a huge amount of attention to the visit, and we script it because it means it's a respectful interaction with the patient. It makes the most efficient use of their time. It allows us to honor the fact that they have usually taken time off of work to come and see us, and it allows us to what's called often max pack the visit, where we want them to get as much as they possibly can, as much value from today's visit as possible. The between visit is where you can calmly pay attention to those who haven't shown up, or to those who have shown up and are not at goal for their chronic disease. And this largely is focused on the sicker patients. And this is where the team meets and starts to be able to really plan your strategy for how to get your entire panel to health, and not just the people that come in all the time. So what we've shown on this slide is that really the 15-minute visit is one of a tiny number of strategies when you're looking at value-based care. That you have this panel management that we're talking about, right, with team meetings. Phone visits actually become important because patients can't always come in, Emails and secure patient portals we use all the time. Health coaches, longer visits for complex, right? People customizing the attention that you pay to different patients and not trying to treat them all the same. The coordination with specialists and the care management functions we're going to talk about explicitly. Group visits are really fun, and using the entire team is really what this slide illustrates, and you're welcome to look at it later. So this is a traditional template. If you push the key again, really what we're doing is we're taking those template patients and we're changing the way we interact with them. And it's morphing into really what looks a lot more like my day, where there's time for e-consults, for phone visits with, right, both the providers and the nurses. The nurses are really focused on care management. And you know that we're really trying to do this because we've just explained to you how we failed in August and we're actually going to do it in September. And this is the vision we've had. These slides are old. I think I did these slides ages ago, probably in 2012. So, right, and we're getting closer and closer to this. This is actually much more what I spend my time doing now than it was when I even did these slides, because this was very, this was aspirational at the time. There's still a need for acute visits, but the huddle can actually occur in the morning with the medical assistant, and then actually often it occurs in the co-location space with the team RN. The physician assistant and the team RN in our world are huddling constantly because we have an interesting team structure, which I'll tell you about, where the physician assistant is really co-managing a panel with an MD and really is the support person for the team in a way that the MD often just isn't trained to do. So using creatively everyone's different abilities because of their different training is another really fun thing when you start to engage with medical home transformation and with teams.
Question? Are you billing for RN care manager visits?
So we do. We have two layers of care management. We have the care management that everybody does, and that nurses will bill for education visits and get paid about 50% of the time. We also have a complex care team that we do not bill for, but they do wind up making essentially 10 times their salaries through cost savings, which as a baby ACO, because Cambridge Health Alliance is part of an accountable care organization, we can actually see now, which is wonderful. So being able to take our hard work and reap the benefits financially and then reinvest that back into the team is part of why you want to move towards value-based payments and towards potentially accountable care relationships and networked relationships.
Thanks. Another question? So have you had experience with call centers versus having your staff on site, answering phones and responding to requests from patients? And have you had any experience talking with people about how it's not such a great idea?
We have a call center as part of CHA in a different region than where Union Square is located. And I am quite nervous if administration is trying to move the call center into our clinic, because probably of your experience, one of the losses is relationship, and also the understanding when you're covering many clinics of the nuances that benefit patients. So my experience with the call center is via my colleagues who work in clinics that have been using it, and they have commented exactly on those things, that they are often on the back end reorganizing patients and into different slots and having to do rework, which is not a good design. I don't have personal experience with that particular call center structure, and there have been so many challenges. I don't know that they're going to extend the call center our way, because we're also not broken. So one thing we have done, however, is not ask receptionists to also answer phones when they're doing registration. And we have a baby call center that has 2 to 3 receptionists in it on site with one of the nurses, RNs, located in it, so that there's a real efficiency in communication and in helping patients in warm handoffs. And that micro call center has been a very successful strategy because it still involves the receptionists that are on the team and that work at the site and that know the patients, but it also allows people doing registration to look at people who are in front of them and smile and interact and not be so distracted that they deliver really poor service to patients. So I'm sure you see what a profound culture change, right? We're all in the middle of, and how really in our experience, because both Nitzali and I worked in the same site before the transformation, right? That really, this is something that is seismic, but it's worth doing. And you actually want to do this kind of change. To do this kind of change, you actually have to engage in performance improvement, quality improvement. The basic tool to do this is actually the PDSA cycle, which we talk about and which we'll continue to talk about. And it's essential that you use these and fail quickly, fail forward, fail fast, get back up, fail again, get back up. Maybe you get it right, or you get something better than it used to be, and then you keep changing. When you change and you don't document, people very quickly, within say a year or two of the process, start to get frustrated and say, well, we used to do it this way and then we changed and I can't remember what we're doing now. And we've both lived through that. You want to say something about that?
Just like the PDSA, one of the ones that we're working on now, it's the defining the role of the LPN and the RN for them to keep working together, but for the RN to focus on patient education. You know, we started thinking about it. We started writing things down in March. You know, we finally got together and put something together. When was it? This past Wednesday. Finally, since March. And so now we are going to start since March. And we're going to see how it goes. And we end the meeting by saying we're going to come back in a month in September to see how is it going, if it's working, if it's not working, what can we change. That's an example of a PDSA. One of them that I also wanted to mention, Maisy, is the you remember the healthcare praxis when we started?
Yeah, I actually have slides of that. I'll let you do that story because it's really fun.
All right, sounds good.
So you can see another way, by the way, folks, I'm perfectly fine if you just want to start calling me Maisy, because one of the other things that makes me crazy in hierarchy is that I'm a doctor and everyone else has a first name, which I just can't totally tolerate. So,
sorry, I do have to mention something too when it comes to culture change. Now that Maisy mentioned it, you know, it really motivated us to do all these changes. Once we started seeing, especially the medical assistants, once we started seeing that the culture of, oh, we got to do it the way they provide, you know, to make the provider happy. We got to do it their way. We got to keep them happy. That was mostly of our thinking, like, you know, let's keep the provider happy so they can have a good day and they can take care, they can give good care to patients. It's not like that anymore, because we used to think that, you know, the provider was in the middle, just like that's one of the slides that Dr. Meisinger showed. Is the provider is not in the middle anymore. We were taught in the culture change in the clinic that is, we're not there for the providers, we're there for the patients. And, you know, the providers seeing us and coming down to earth, like we'll you know, see it, treating each other, respecting each other, and letting us be part of them, letting us be part of the team, really did help to change the culture. And just see the patient as the person in the middle. Just, you know, see the patient as the person that we're there for to do everything. So that was one of our biggest culture change that I saw in Union Square. And you know, it had to do a lot with respect and giving us the opportunity to do things for them and giving us the freedom to be part of the patient care. So I'll give it back to myself.
It's also, by the way, from the provider perspective, a lot less lonely. I feel like you have a community that you come to work with, and it can be very lonely being a PCP, and going from room to room, and just seeing patient after patient after patient. That really is gone. I feel like I have a community that's helping me take care of a challenging patient population, and that has made a big difference to me as well. So here's our structure. We have an impaneled provider and we have a non-impaneled provider. We share a panel of patients, and I now have a panel of 3,000 patients with 4 sessions a week. And I have, which is really high for a safety net. I also have really high quality metrics. So my P4Ps, if you think of them that way, or my levels of patients that have controlled A1Cs, and my levels of patients with controlled hypertension are quite high. Often as high as many of the private systems that you hear about in the country, and we can show you all of that data because we also have it entirely transparently across the organization. The nurse really is focusing on chronic disease management, but we keep getting them sucked into the triage and telephone monsters. We have successfully stopped them from faxing now for about 5 years, which is, a major victory, but at the same time, it's really challenging to help nurses focus entirely on the patient because they are superheroes and they will do anything for anyone, anytime. So in some ways, they're their own worst enemies, and they, I think, have to creatively learn to say no to things in the medical home environment, which goes against their training. So there's some interesting learning in all directions. LPNs, as you know, we're evolving this role, and we actually now have, Nitzali is actually managing patients with asthma and is doing the care plans for those families, for pediatric families with asthma. And we're trying to expand the role of LPNs in a way that's going to facilitate better care for our patients. The medical assistant is the boss of the floor and has their own panel of patients that they take care of as part of their care team. Currently, we have medical assistants responsible for getting process measures for diabetes, meaning they are responsible for making sure that patients get A1Cs, urine microalbumins, LDLs, eye checks, foot checks, depression screening, and we have registries that support that we'll look at later. The receptionists also have panels that they are responsible for. They are currently responsible for making sure we have our well child visits up to date, and pap smears are being booked when they're due, and they're including abnormals. Although they work with the nurses to help make sure that they're doing good clinical care with the abnormal pap smear lists. And our patients are on our teams as well, like I mentioned before, and a very important part.
There's a question.
Oh, I figured.
Yeah. How did you roll out the Patient Partners program? Did you have specific patients in mind, or did you ask for volunteers?
So we did that the way we do most things, which is we held an all-staff meeting and said that we know we need to do this in a more formal way. And we asked all team members to think about patients they thought would be good as patient partners and to nominate them to us. And then the performance improvement team was going to use a tool that I'm happy to share with you that Cambridge Health Alliance has published, that and that is part of the public web if you want to go look for it, that is guides teams and clinics in how to engage with patients and how to choose patients. So as we do, as Nitzali said, everything requires buy-in from everyone or it's not going to succeed. So we always start with a large communication focus and ask for the help from the teams to find folks that would be appropriate.
Thank you.
Just want to add to all of this role definition. When it comes to all of these things that we are responsible for, I just want to mention that we do get training. For example, the medical assistants, we got really good training when it comes to managing the diabetes list. Meaning they were trained if the A1C was a certain amount, the patient are supposed to come back every 3 months, or if it was this amount, the patient doesn't have to come back every 3 months, they come back every 6 months, like how to outreach these patients. It's all about training and teaching, which all of our providers are awesome doing it, and so this is why they are able to know and who to outreach and when.
It does require the practice to agree on things, because you have to move away from doctor as God and deciding that I want to do this even though evidence says it's better to do it another way. That is an important conversation, and I kid you not, we spent an entire hour provider meeting arguing about where the label was going to go on the pap smear bottle. We did not have to spend that much time on such a small decision going forward, but that was an important part of our culture change. It was important for providers to learn to let go, and that for them to understand that it was not respectful to ask the medical assistants to memorize where every provider wanted their label to go on the pap smear vial. Can't make this stuff up. So this is our team training, as Nitzali mentioned. This is actually art as team training.
We have fun too.
But we do try and keep things fun so that people are motivated to keep their energy up. It's still a tough job, guys. It's not nirvana. We take care of a challenging population, and we have to, I think, feed ourselves as well. That's partly why we have really high staff satisfaction metrics as well. We have more of an extended team than before, which is really fun. I'm not going to get into the slide because it's a lot of people. Until you have a team to be able to manage the coordination of your patient care outside of your clinic, all of this just falls on the provider and they want to cry. So I now embrace the extended team because I'm not doing most of this. Much of this is happening at the team level, and they let me know what I need to know. And they ask me questions when they don't know. And that is really a satisfying interaction. And I know that the patients are benefiting from this extended team now because we are able to focus on them and offer these services to them in a way that we were honestly too overwhelmed before to be able to do. And so care coordination is everybody's job. It's actually really essential that we stop thinking about care coordination as a complex care team or a care manager's job. Everybody that calls the clinic every day needs care managing, and receptionists and medical assistants are incredibly important for this. So there's a little set of thoughts on this slide for how we think people are already doing co-management. What it winds up looking like is people get co-visits, so that if they're going to take a morning off of work or a day off of work, they can get multiple appointments done at the same time. We try and do sort of extra things for patients. If I know I'm seeing someone whose asthma has not been in control because they have had trouble managing it and really understanding what it is, which is pretty common, we try and set up the nurses to be able to come in and do the teaching because we're looking at the schedules ahead of time so that we make sure that they're available. We try and also do the same thing with behavioral health, and we have a very motivated, very gifted team that is able to now take the patients off of our schedule in a way that feels value added to the patient. Instead of having it feel like they can only trust the doctor, they now have a team of people that they can actually tell very intimate details to and really move forward on some of the very traumatic experiences that about 70 or 80% of our patients have actually had. And we've been so, I think, floored by the things that we have discovered by having integrated behavioral health that we're actually looking to publish something about the really high levels of trauma in our patient population that really we didn't understand until recently. So care coordination really requires also you making sure that when patients go outside of our clinic that they know they can come back safely and that we can help them navigate the larger system as well. We have very scripted interactions for the entire team for how to do that. communicating team is really important. This is a very old poster board. These are actually a few people still here.
Not everybody.
Yeah, Mirna and Ellie. And some of them are at CHA in other roles, but a lot of them are actually have moved on. But this is, this was early times, and there's nothing wrong with using a simple poster board to explain to patients what different people in the clinic they're going to see do for them. And if you can, it's hard to see on the slide, I apologize, but you can blow it up when you have the slides yourselves. We tried to write it in actual simple English, right? If you need a referral, talk to this person. If you need a lab done, talk to this person. If you need this thing, right? If you need, if you have a question about your diabetes, please talk to your nurse. And we try and do everything from the perspective of the patient so that it feels like it's written for them and not written at them. So here, I think we can pause. And we have an exercise for you to try and have you to reimagine some of the work that you are doing now with extended team members and the core team members. And I'm going to maybe lean a little bit on Luce to help guide you in how to do that, because we are not in Rochester.
Right.
Unfortunately.
I know, we're very sad.
Okay, so we do have some M&Ms coming around in our groups. If you can reconvene into the different groups you were assigned. I know we moved.
Okay, guys. No eating the M&Ms yet. You still have to count them. All right, so let's do a quick debrief from the teams, right? So let's go quickly around to the different teams, and you can just shout out loudly, please. Who has the most M&Ms? Which cup is the most full?
Dr. Meisinger, can you put your video back up too, please? Thanks. So it sounds like provider was number one, care manager, RN.
2 care managers, 3 or 4 providers.
So who has the care manager doing the majority of these things?
They said the smart people.
They said the smart people.
Want them to comment?
Did you want them to comment?
Yeah, I would. Thanks.
We, in our group, there's 2 of us that work together in the same practice at the medical home for pediatrics, and we have care managers that run our data lists and look you guys have been coming in your appointments and make phone calls and seek out assistance for clinical information to determine if people want to come in. So it deems them pretty competent.
So it's from one practice that has a couple of folks representing them, and they are a pediatric practice. One more comment. We got another team.
We did not have as many as the providers, but I think we came in a close second for care management for our practice. And our care managers do a lot of the work. They do a lot of the health maintenance, the transitional care, the complex care.
Great. So another team had the care managers a close second in supporting all the activities.
Okay. Can you go forward to the debrief slide again?
Sorry, what was the question?
Can you move the slides forward to the debrief slide so everyone can see the questions?
Yep.
Thanks. All right, so what is the cost, do you think, of providers doing all of those things that you saw on the list? What are providers currently being paid to do? Right, so what I'm getting at is in a fee-for-service world, how many more visits could your providers be doing if they were not doing the things on that list, right? And you don't have to answer the question, but unless you're in our shoes, and we're going to be 85% value-based payments this year at Cambridge Health Alliance, that's probably costing you money, actually, right? Having it set up that way. And do folks feel like everyone's skill set is being optimized by having that? Yeah, I didn't think so. Or I guess you wouldn't be in the room, right? Now, who do folks think in the room? What do folks think about what are the different roles that are currently in your clinical environments that you think could take some of those tasks on? And just shout out roles really loudly.
Medical receptionist is one.
Yeah, excellent. Woo, good one.
Data coordinator.
Data coordinator. Some teams have data coordinators.
Yep, quality manager, data coordinator. We call ours planned care coordinator. Excellent.
So I also think that they have the advantage that their LPNs and MAs have a broader scope of practice than what we do here in New York. So our LPNs can't do a lot of things that I think their LPNs can do. So it falls back to the RN. So now the RN doesn't have the opportunity to do the chronic management, the population management that they could be doing. And instead, they have to do a lot of the things that I think their LPNs can do. So.
Yeah, so the scope of practice issue in New York State.
Yeah, there are some hard stops that you run into with rules. They do move. You do want to start to make some noise about what you need to change and how to be able to do this kind of care successfully. But there's always creative ways around those. So I encourage you not to view that as a hard stop, but as a sort of call for you guys to be creative and go around it. So here's an interesting.
There's one more question or comment.
Go right ahead.
I did have a question. In your setting in Cambridge and your area, are you having medical assistants put orders in the electronic chart? Is that allowed?
Do you have medical?
Here, at least in our institution, it is not allowed, and therefore we have physicians and nurse practitioners clicking 29 clicks to get a mammogram in and getting orders and associated with the right ICD-10 code. When you can have a manager doing that, don't 29 clicks.
Yeah, can the medical assistants put in orders, because here we can't?
So by protocol in any state, medical assistants can do more than they're doing now, but you have to have policies and protocols in place, and that's a fair amount of work. And we've spent a lot of time and effort writing policies and protocols to support this work. And I highly suggest that you simply borrow other people's and not start from scratch. Kaiser has a wealth of information out there. They have wonderful policies and protocols to adapt. And that's one place to start. I'm sure that's one place that the PTN could actually help as well, start to get some of those together. There is a website called improvingprimarycare.org that is out of the Robert Wood Johnson work that Nitzali and I are familiar with, and has enormous numbers of policies and protocols on it. And those are all available. That is out of the LEAP initiative. Those are a lot of our organizations that participated, posted their work on that website, and you can take any of it and adapt it.
Just for the room, I think that.
So, Luce.
There's one more comment.
Oh, I'm sorry.
I think it's an institutional overinterpretation.
Yeah.
So I don't know how this is at other institutions locally, but I do think that we probably need to band together within institutions and across the regions. I don't know if Common Ground can help with that, but there are a lot of really pretty ridiculous roadblocks to enabling other staff to do some of these tasks.
Yeah. So they're talking about over complicating the requirements. So they're having a little bit of discussion about how we can collaborate together across the counties to help move that.
And the licensing related to the MAs, LPNs are.
We have a workforce initiative going on at Common Ground Health as well.
Having worked with multiple practices, private and system-wide, you're right. The interpretation is often the issue, and it's whoever, sometimes it's the billing person saying, we shouldn't be doing that. And there's no clinical reason for them for someone not doing it that way. So yes, you're right, and we need to do more of that, and hopefully within getting groups like this together, we can explore and have that discussion.
Thank you. Dr. Deschamps, did you have a question? Yeah.
Yes, Dr. Meisinger, my patient population is, I have a practice with an identical patient population as yours, and one of the barriers to RN care managers that they're so overwhelmed. I'm just curious as to, I know your RN role is not developed yet, but any idea in terms of what's an ideal caseload for an RN case manager for a patient population like yours, based on your interaction with other systems?
Yeah, so she's asking about RN care manager caseloads with a similar practice demographic to yours.
So we actually have an RN care manager and a social work care manager. Many of the most challenging patients actually are more appropriate for social work than, and the RN really is supposed to work on the medical illness, so COPD, CHF, end of life things. Because we have mostly Medicaid population, I would say our social worker is twice as busy as the RN, and so we're actually decreasing the number of RN care managers that we have across the system and increasing the number of community health workers actually that we need. So I would actually suggest that you start with the community health workers and maybe see if you can have supervisory social workers for those folks. But the number of RN care managers that you actually need that who are going to be managing active medical issues is quite low when you have high functioning teams, because the care team itself takes that on and you don't need to have it be the care manager. So that the pediatric practice that has the care manager doing many of the tasks, I'd really be interested when I do get a chance to visit you guys to have a conversation with them, because we do tend to medicalize things that are not always best cared for in that context. And there's some very good studies that are also on the improvingprimarycare.org site about care management. The most cost-effective, most highest or really highest quality interaction is actually a system that uses community health workers and not a professional designation. So I encourage you guys to explore that. People need other people to help them navigate a complex system. They don't necessarily need education about their chronic disease to get to an appointment after a hospitalization. So we may have been asking the wrong question for quite a few years in trying to look at helping patients when they're acutely ill. So I want to move on because this is the active phase of your experience today. I want to make sure we have time to do the huddle sheet and the worksheet for teams. But one quick comment on the M&Ms before we move back to the slides, although what you're doing is fine. That's great too. It turns out that the providers, this slide set was specially designed so that not a single task is supposed to be done by a provider. Not one. So I suggest you either redistribute all the M&Ms in the provider cups or eat them.
Eat them all!
Not that we're gaming the game or anything, right? But that I think people find shocking after doing this exercise, and it's partly why I actually enjoy M&Ms, but I also really enjoy the shock that I felt the first time I had this exercise.
Yeah. There's another question.
Some of the suggestions you're making, I come from a very small private practice where there is no data coordinator, there are no MAs, I'm the only RN and I'm the care manager. So some of the suggestions and resources, are they geared towards both system-wide practices with a lot of resources as well as small practices?
Did you catch the question, Kirsten?
I did. Sorry.
Okay, so the question was from a small rural practice that doesn't have the list of resources and other functions in the group. How do we adjust or modify to meet the team approach in that setting?
So small rural practices in the United States look a lot like Australia, actually. which I work in as well, doing medical home transformation. And in fact, Australia is really stripped down. They have a receptionist, maybe a few nurses, and providers actually rent rooms from practice and are completely independent. So they don't even have practices that are coordinated as practices, which is an interesting model. They also are moving to a very different model because they recognize the exact same challenges that we do, where, you know, chronic disease and care coordination are very difficult in that schema. So you could vacation in Australia. That sounds actually like a great idea, to investigate this more, but that's not actually where I'm headed with this. I think what you want to do in that case is look very critically at what are the value propositions financially for your practice to try and see if you can get more help after you have already maximized the people who are you're currently having on salary. So it's exactly the same process. It's going to not be as rapid because you don't have human beings around to simply hand or redistribute tasks to, but it's not actually fundamentally different work. It is basically the same strategy. It just requires much more careful financial planning because your margins are that much slimmer. And I have a worksheet that I have used that I'm happy to share with Brenda and Luce, if that's helpful to folks to see what some of the financial modeling looks like, and see if that's of interest to you.
Great, yeah, we'd like to see that. Thank you. Another question?
All right. Oh, great.
Yeah.
Just a comment in regards to this exercise. I'm wondering if you might want to, you've spoken about the patient being part of the team. And I'm wondering, looking at this list, there probably are some opportunities there that if the groups put a cup there for a patient, they could rethink this.
Mm-hmm. So the comment was, you mentioned the patient being a part of the team, and that if we actually had a cup for the patient, we may redistribute things in their cup a little differently.
Absolutely. I think that's a wonderful comment. Patients have so many strengths and assets that we are not really respecting and encouraging and growing. And I think that's it's a very powerful way to think about care, is to redesign care using patients as your guide. It would look very different than what we're doing now.
Great.
Okay, so we're talking about the difference between a meeting and a huddle, right? So a meeting is the time where you try and focus on patients who are not coming in for care or are not currently in front of you, and a huddle is planning the work of the day. So we're going to, next slide. There's some details on that slide that we don't need to go over right now because you're going to build your own. So the essential components of the huddle. Continuity is really one of the unsung heroes in primary care, right? I think Nitzali's spoken quite eloquently about why continuity on the team level matters. Patients need to identify one member in each role and really start to interact with them in a meaningful way to build that relationship. So continuity and consistency are very important with the people who are going to be working together. You can't form a team if you don't have the same schedule. So you have to also, if you practice things, you get better at them. So if you are consistent and you do the huddle every single time you meet, it will be that much more efficient. It will feel that much more important, and it will actually simply bake itself into the air and the water. And it's such an easier way to interact that it feels entirely natural, and it feels actually a bit strange when you don't do it. Pick a place that's realistic. Don't pick a place that's hard to get to. We actually have co-location rooms. We've taken broom closets and other crazy structures and just shoved people in there. Everyone has to shower every day. I can't say that loudly enough. When you're on top of each other in a small space, you get to know each other really well. And it's actually a joy over time. But you do want to be as close to each other as possible, and we actually seek those interactions out. Don't do the work during the huddle. please. It is very inefficient and annoying. Just take, I was actually timed. It took me all of 4 minutes to go through my list for a session. So it should take me all of 7 or 8 to go through an entire day of patients, theoretically. It really gets easier as you do it more often. But part of respect is that you know that everyone has come to the huddle with their list reviewed and with any questions and thoughts prepared. Respect people. Introverts need to probably have moments of silence to be able to speak. I am clearly not an introvert. I have tried to learn this lesson well. There is really, speed and focus don't have to be goals. They actually happen by themselves. But you really, this is not the time to start telling long, meaningful stories about people. This is about how are we going to get through the day? How are we going to get home to our families? And how are we going to feel really good about the care we delivered today? That is largely, in my opinion, up to the medical assistant. If you free the MA, she will do amazing things for you and your patients and herself. I run behind much less often than I used to because Carla has really taken me as a project. And boy, was I a project, because I love people and I love to talk. So I can say from experience, it works. People used to go out and get dinner and then come back when I had evening clinic. And now I'm probably no more than 10 minutes behind most clinic sessions, and that's largely due to the team. You're going to design a huddle. If you're already doing a huddle, you're going to take a moment to look critically at it and decide what you like and what you don't like, and really what's working and what's not working. And if you can't, if you don't have the correct team members present to do that, I think you want to look at the sheet and maybe plan who it is that you're going to at your site ask to do this exercise when you get back. There is a concept in medical home transformation called the pilot team. It's usually an enthusiastic group of people that really want to embrace this change. And so if you don't have one, I'm happy to speak a little bit more about that, but I suspect most of you have heard of this and have them firmly in place at your clinics. They're very useful. They should not be leaders because they essentially show what's possible with the vision in a way that leadership will benefit from, but does not then have to actually do. Although honestly, leaders should be doing it as well if they can. So why don't we take a few minutes to do that? I'll just depend on Luce and Brenda to let me know when it looks like folks are pretty much done. This can take anywhere between 5 and 15 minutes depending on where folks are. So, and it's really hard to see you guys. So get started and we're available for questions. Get out. We need to get out. You can say, yeah, you know, today actually I have to go pick up Rowan from soccer, so I can't really add anyone on. Sorry, you know, just, you know, let them know that, but I can add people on tomorrow, you know, if you get in touch with someone. That kind of flow, it's wonderful. The team is really often very happy to take that on, and I think it's really wonderful for everyone to feel like they can have control over their time. That is one of the most challenging parts of primary care. So just as a thought, Nitzali, do you have anything you?
No, just adding to what you had to say, even if you have to leave early or if the patient comes in late, just notify the medical assistant too. You know, if the patient comes, like the rule, if you have at your site 15 minutes after their appointment time, sorry, tell them that I can't see them. They'll have to reschedule for another day. You know, things like that will help us to manage the workflow too of the morning or afternoon. Yeah,
that's a really good point actually, which is, you know, just what can I do today? What can we do today?
Right.
You know, knowing that often I think if Nitzali had to leave early for some reason, she would say, I'm going to have to leave at 4. I won't be able to be with you until 5, but right. Joanne's going to cover. So just, you know, page her after 4, and she would always come and say goodbye to me anyway, just so I would be focused. So that kind, and then we would do what we call the rolling huddle as well, where we would constantly be checking in, and I basically would say, okay, boss, now what do I do? Okay, where do I go? What do I do? Tell me what to do. And so I don't have to make decisions. It's actually the medical assistant who's doing it. But that was beautiful. That was great. And starting with the personal, but not getting too deep into it. Very well done. Big fan of humor. Okay, so Luce, we can go past the break because you guys broken. All right, data. Woo! Nothing says excitement like late afternoon data. Right, so data, doctors talk all the time about how they love data, and then they, fall asleep in data meetings, or, announce that your data is not actually relevant to them, that they're a better doctor than that, and all sorts of other interactions, right? So let's actually just take the bull by the horns and talk about the data. This is one of the only ways we have to think about patients we're actually responsible for, but they're not in front of us. And so having a team that addresses this outreach component we talked about and the population health side of our responsibility as primary care deliverers is a really important component. It sounds like you guys have wonderful care management teams and are really engaging with that, so I'd love to learn from you. And it's really hard to do that on this weird video, but we'll try. So we should definitely have that be part of the conversation as we go. But the idea is that we are responsible for people even if they don't come in. We still own that. One of the ways that we think about this at Cambridge Health Alliance is we have sort of prevention, disease management, and then also complex care. Next slide. It can get wicked complicated, as we say in New England. So there's all of these different metrics that we're following. We actually were asked to follow 524 different quality metrics from all of the insurers that we interact with, which basically made our heads explode. And that's not a viable strategy. So what we did is digested the ones that we thought had the best overlay between the quality work that we really believe in, right? Tobacco cessation. I will go down on that sword. That is a very important thing to do for our patients and to help them do for themselves. And then we also had to look at what would be allowing us to continue to be financially viable. So this is really what we came up with, this schema. And you'll come up with your own. But we dividing it into these basic categories is another way of breaking down the work. It's same basic strategies and tactics that we've talked about before. On the ground, it winds up looking a bit like this. This is a team meeting schedule. It looks complicated. That's because it sort of is. We've gotten really fancy as we've gotten really good at this. You can do this in a very stripped down version. You can do 1 week, which is diabetes, another week, which is depression, another week, which is hypertension, and just make it very simple. Initially, it's actually helpful to have every single team member present every single time. We still try and have the majority of the team members present at meetings because it's really important to have that interaction as a team in a calm, thoughtful way, the way I think we've talked about already. But you can also use this team meeting time for certain people to actually get the work done, because it's quite a lot of work to take a panel and actually try and make sure that everybody is at goal for all of their necessary quality goal, their metrics. So I'll let you guys digest that later, but sometimes what we'll do is during the complex care week, we'll actually have the medical assistant and the receptionist off doing their quality lists and not necessarily having conversations about folks. Partly it's because we have so few people in complex care now. We really do have the team managing most of them. And most of them are actually pretty stable and are no longer, the number of emergencies really has gone down to almost zero, which is just a joy, because the emergencies are the things that I think make us crazy. So you can have registries that are quite simple. And this is actually our original registry that was really just a glorified spreadsheet. And what we've done is we've broken it down into teamlets so that you have a providers panel listed with all of the quality metrics cross-referenced. And this is what I used for years. It was not integrated with the medical record. You'd have to go find it. You wouldn't necessarily, this is just the roll-up of how you're doing. You wouldn't have a patient list that's associated with it. It was just a sort of quality dashboard for us to see how we're doing and where we need to focus. Yellow was bad. I'm trying to remember, it's been a while.
Yeah.
Right?
Yes.
Yeah. So next slide. We've got now, I think, appropriate IT support where we actually have dashboards for every single person at Cambridge Health Alliance that has a panel. I can see how they and their team are doing. So it's entirely transparent. You can see how they've been doing over time, and you can see all of the different metrics which we've actually nested so that there's a definition of a diabetes perfect care interaction, which is actually quite hard to achieve. because it involves almost everything someone might need in a year. But you can look underneath it and see how you're doing with tobacco screening and cessation for your patients with diabetes and other things.
Oh, question.
This is our actual, question?
Yeah, just the question was which medical record, which program are you using, software?
Epic,
Epic.
actually.
Oh, okay, thanks.
It actually came right up on the slide just as she was the person was asking. So this is a registry. Epic has great functionality for this, and it pulls now. We actually have a registry that pulls right from the medical record, and so it updates every 24 hours, which means effectively it's always updated. Every single staff member at our site, as you know, has their own panel. So Carla, who is the medical assistant on our team, actually now has her diabetes list organized the way she wants it to be, because she can actually set those parameters. And the same patients are organized in a different way for Esme, who's the nurse on her team, who is responsible for patients who are not at goal. We also use the extended team for challenging management managing challenging conditions like diabetes. So pharmacy is an important component for us to manage patients with a chronic disease. They do COPD teaching, they do CHF teaching, they do hypertension management and diabetes management, and they're quite a secret weapon. I highly recommend having pharmacists, and they can bill, which is another important component. Yeah, oh, they do all the AMS clinic, right? They do all the Coumadin and warfarin management. So which is also a huge help for the registered nurses too, and providers, because she not only helps them and teach the nurses at the same time, but also takes on educating the patients. So it's a huge help for the nurses too. Exactly. So the registry, remember, I think we had mentioned, I want to just highlight this point, that having the same people responsible for outreach as inreach means that they are highly motivated when someone comes in to get everything done, because if they don't, it's going to be their problem anyway, and they're going to have to figure out how to get the correct phone number for a person when they had been in front of them the week before. And we had really interesting cultural movement along team lines with our medical assistants, really calling each other on the carpet and holding each other accountable for not doing that work on behalf of the other when they weren't present, or if a patient had to go off team for some reason. And it's been probably much more effective than leadership trying to make sure that people do the work, because they actually now, any new hire immediately just gets sucked into this culture of accountability, and it's done entirely laterally. It really does not involve me at all, ever. We do have regular meetings where we look at quality metrics as a clinic and make sure that we're at goal for what we want to do. And when things are not going well, we actually figure out together what we want to do to try and make that right. And that process, I think, you have to be very careful not to be blaming or select individuals. It's a tricky conversation, but it's an important conversation, because leadership has to give the message that this work is essential and it's not optional. Your team will meet, it will meet regularly, and even if it's one person, you use that time to go over the important work. And that's actually what happened to my meeting this week, because I ran over and I was texting Esme, and she actually she said, I'm by myself, but I've done the list and there's nothing for us to do. It's already up to date. I did it last week. And I was like, well, I'm not sure why you needed me, other than I can tell you that you're awesome. So, but I actually made sure to go get Carla and Esme and I together in the co-location space right after I should have been at the meeting because I felt bad. We actually checked in and made sure that as a team, there wasn't any hidden resentment and Carla actually had been stuck on the floor because there'd been a call out. So again, my point is, it's not nirvana, guys. We're not perfect, but this is important work, and over time, it yields tremendous results.
Also, sharing all of this information, quality measures, with all of the other staff, including all staff meeting, it's so much helpful, because they see the results of the work that they're doing together, and it actually, if it has improved, they really get motivated by looking at all these changes and looking at the numbers improving. They really get excited. starting from the receptionist, everybody. And so this is one of the motivations that takes them to the next level, that they want to do more. So I just want to emphasize on that too.
So PDSA, right? Please do it. Next slide. You need a piece of paper, you need some markers, you need a hand, and you need a team. That's all you need to do a PDSA, right? The most important thing about PDSAs is figuring out ahead of time what you're going to measure and then actually doing it.
At this point, our conference room, it's full of long papers with PDSAs that we have to go back to. So, I mean, like she said, it takes time, but as long as we put it together and we go back to it and see if it improved, if it hasn't, what to do. I think that's just the important point, just to get to results.
Amen. Next slide. So the team needs to get right fast QI and PI. You need to use the coaches that you have with your PTNs, right? Organize your sites. This really, if you get nothing else out of today, I really would like you to go back with the sense that structure matters, right? It is your job as the leaders and the champions to go back and ensure that there's structure in place, and then hold people accountable to engage with that structure. And then it's up to them to do the right thing. But people generally do that. It's just hard to get the structures in place. So part of structure is dividing the data into workable chunks that don't overwhelm folks. It's easy in the United States to use panel by PCP because it's on everyone's insurance card. And accountability is really easy when there is a single human being that you can look to and say, Joanne, what's going on with the mammograms? You need help, right? It's only Joanne that is going to be managing Dr. Thackeray's mammogram list. Why is it not happening, right? You can sit down with her in a way that's respectful and private and make sure that she's okay. That kind of accountability yields results pretty quickly. We have some other workflow team ideas. And I had mentioned this before, the performance improvement team is a team that gets extra training in quality infrastructure and performance improvement and meets twice a month and has patients that are actually part of that group. They actually decide what they're going to work on together, and they work on issues that cut across the clinic. And we can talk a little bit more about that. But first, let's talk about an example of how culture changes when you engage with this process.
So a little bit going back to PDSA, we have an example of the healthcare proxies that we give out to patients. Leadership came to one of our meetings, and I was still a medical assistant, and they said, okay, guys, we need to, by the organization, we need to start doing this. We need to start giving these out to patients and having patients assign a healthcare proxy. And, you know, all the medical assistants were like, oh, okay. We left the meeting, and in between us, we were like, okay, let's start doing it this way. So leadership had no idea that we had started doing it as a group of medical assistants. We decided to start giving it to the patients, having them sign up for it, and go from there, try it to see what happens. Next week, we came together and we told leadership, healthcare proxies are being done. Patients are doing them. They're being scanned. And they were surprised because we took over the PDSA. We put together the workflow. We tried it. It worked. We kept it. And as to this day, we're still doing it. They're still doing such a great job with it. And leadership just had to say, guys, help me get this done. Okay, we did it together. So that was just an example that a PDSA that really worked very well. So, I mean, again, leadership engaging us in making decisions has been one of the biggest key point for us to be able to, you know, help in the workflow. Yep, this is the reaction they got when we came back. Healthcare proxies are being done. They were jumping around. Yay! Next. All right. I like this slide just because I'm really proud of leadership letting us do this way. So when the training, I already spoke about it. We get trainings from the providers if they need to get us together to train us in things. So that's really good. We take it, we do it. But also when they come to hiring new staff for the site, this was really surprising for all the other staff. They include us in the interview process. Every single title, whoever is available goes into the interview process, and we interview the staff, and then leadership comes back to us and asks us, what do you think? Do you think this staff member will be a good fit for this position? And they really listen to us. They really count our inputs, what we have to say about, the interview. Once the staff is hired, they also have the staff spend at least half a day or half an hour with each title that works in the clinic, because we feel like it's very important for, even if he's a doctor, they sit down with every single one of us, LPNs, RNs, front desk staff, referral coordinator, and they see what we do. They take notes. They see how we engage with patients. They see it all. So that way they have an idea of what we go through on a daily basis. So that way they can also work as a team, include themselves into our busy life during the day. So I think I think that's one of the biggest key to work together, to get to know each other. So it has worked perfectly. So far, so good. And we're loving it. RNs as team leaders, we already spoke about, taking away all the stuff from the RN plate so they can focus on the chronic illness care management. Like we're saying, we're trying our best to give them times to focus on those kind of patients. Us at the LPNs, we're taking over more and more from their work, so they can focus on that.
And they're really, now the RNs are able to do this when they touch a patient that they know is has these conditions, but they're not getting time to do the outreach part. So again, this is that balance between trying to make sure that when people are in front of you, you're doing a wonderful job with them, but that's actually not good enough. You have to go find the folks that actually need your help even more. And that's what we're having trouble getting the nurses free time to do, but we'll get back to you. We'll let you know how it goes in a couple months, because we're studying it and working on it.
Yeah, that's one of the things that came up during the meeting this week, is that the RNs want to meet face-to-face of the patients with the chronic disease, so that way they know that when they're outreaching them, they have a face. It kind of helps them to know, oh, wait, Amberly is calling me. She must be following up on my diabetes. So that's one of the things that we're going to be doing PDSA on. Warm handoffs, that the providers will get the RN or the medical assistants to come and meet the patient and tell them, I'll be outreaching you to follow up on your medications for your diabetes or so forth.
So we're going to actually, we've asked teams to actually integrate that into the pre-visit work in the huddle in a much more intentional way than we have before. All right, we're getting to the point where you guys are going to start to design your own team meeting structure. So one sort of, I guess, extra credit, if you would like to do it, is designing your own performance improvement team. If you already have team meetings in place and you're happy with them, and you spend a little time maybe thinking about it and as part of today, and you're done with that, I've included some extra things you can do, one of which is this performance improvement team. So it takes one of every role and it puts them together, including a patient or two. And then you actually look at different kinds of tasks. And you can see some examples there. Healthcare proxy was actually on this list, and then the medical assistants just did it. So I left that alone because I thought it was a valid point, actually, that we had intended to get to it, but actually didn't have any time. Next slide. Oops, sorry.
I'm not sure about the improvement team. We do have, it's made of different titles. There's a receptionist, a doctor, one of the managers is one of every single title staff. It's included in that team, just so you guys know.
Yep. Next slide. So, and then the last part of the workshop activity that we're going to do now is also about where are you getting your data? And this is a really tricky one because so many folks don't have what they consider to be reliable data. And by reliable, I mean actionable. It comes in an action-ready format. It comes in a way that you can actually give it to teams and have them do something useful with it. And it's very hard to get real-time data. A lot of people are still working with billing, which is by definition at least a month delayed, usually more like 3 or 6 months delayed. So I didn't put that in there to depress people as much as just to know what you're dealing with and to think about it and figure out what are the other ways you can actually get data that's going to fulfill all of those criteria. And then once you have your data, how can you structure your work with team meetings and other interactions to make sure that you're actually doing something with it. So if you go to the next slide, Luz. The workshop activity now is there's some sheets. There's team meetings sheet. There's a workflow team or performance improvement team sheet, or some I think just thoughts for you to work with. And then there's some questions about data. So for each of those, really you have to think about roles, and you have to think about function, and you have to think about schedules. So it should be the same teams that you are working with in the huddles. The continuity, reading the rules that we went over before apply to team as well. Continuity, consistency, and please take a few minutes to do that. Again, can take anywhere between 10 minutes and half an hour, depending on how people are where they are and how useful it is. So I lean again on Brenda and Luz to be our guide for when you're feeling like you're done. After this, we don't have very many slides, and we've been asking questions during the session, so please don't rush if this feels like it's useful, but then again, never hurts to get out early.
Okay. Okay, so now we'll break back into our groups and take a look at the team meeting structure and workflows. Okay, I think we're back.
Good. All right, let's do a bit of a debrief. If you could find a team that is willing to share what they just spent the past few minutes doing, that would be great.
Would any teams like to share what you came up with?
Volunteers, volunteers, volunteers.
Sure, Dr. Deschamps. Great.
In Anne's office, a lot of actually, they have team meetings every week, and usually providers and nurses are there, care managers are there as well, and they actually usually focus on population count, so they do a lot of crime disease management, and what the focus of the team meetings are, usually all providers, usually provider driven, and I have shared with Anne that in our office we have weekly team meetings that's usually involves a care manager, social worker, provider, and LPNs, and it's usually to focus on our high-risk patients, chronic disease management, and the agenda is usually set by anyone in the group. So it could be the LPN that brings it to the podium. And I was just discussing how one of the challenges we have in our office is that sometimes we are just so busy that we just forget to meet, which is actually the downside. And I was sharing our challenges with getting data on a timely basis to work on practice management.
Okay, great. So Kirsten, they mentioned that they are from two different systems, two different parts of town, so very different dynamics, but both conduct weekly meetings, which I think is fabulous. Although there are some challenges with data, as well as just remembering to have the meeting. So back to some of the comments you made about structure and that accountability, that to keep it going can be challenging, but it sounds like you have at least the pieces of it. in place to have the conversations with a cross-functional team that either focuses in on chronic patients or specific care management needs or other items that come up in your practice.
One suggestion for keeping track of folks that works quite well is if you want to start a Google Doc or a Google spreadsheet, and you can actually have team members when they attend enter in their attendance with the dates, so that it's a decentralized system, but then you actually have a record that people actually gathered together and met. And the nice thing about Google Documents is that it's a computer, right? It documents at what point they entered in that they were there. If they're entering it during the meeting, you can see that they were actually there during the meeting. And so, there's some silly behavior sometimes if you don't have everyone, as we say, if you don't have the right people on the bus, sometimes people try and, say that they were there and they weren't, or you can't get good information. And, these are headaches that leadership often has. Is the more transparency you have in these things, the better. So it's clear who entered the names and when. But that's one idea. So that accountability it really, I don't think we've kept attendance for years, because once you get into the culture change where people understand that this is a way to take better care of people and that they have pride in their work and they want to go to the meetings and take good care of their patients, you don't have to do this. But to get it started, it's okay to do things that are a little bit sort of, I think, not tight, but accountable, right? To demonstrate that you're going to be checking is actually okay. Unrelated, any change that I think we've learned over time, you're going to institute a change, you're going to have to check it daily for a couple weeks, and then you switch to weekly for a couple months, and then really after 6 months you can start to do spot checks. So careful, folks who are leaders in this room, what you take on, because that is a lot of checking. And you can very easily get in a position where you're taking on so many new things that you're actually not going back and making sure that things are happening. And that's a dangerous situation, because then people don't believe you when you say that something new is going to happen. So be careful with yourself and make sure that you are able to maintain that kind of pretty intense cycle of checking, so that you're able to really keep the folks focused and aware that you mean it. Could someone else come and give us a sense of how this time went? But if you could come up to where Luce is, that would be great, so we could just hear you a little better.
Would anyone else like to comment? I'm hearing crickets and no one's making eye contact. Not sure.
So did anybody take on the performance improvement team?
No, I think it looks, I'm getting some shaking the head, not nodding. So they focused in on the team meetings, I think.
So let's see, Luce, give me a sense of how many folks have team meetings in place right now.
Wow, like 75–80% of the room is raising their hands.
Okay, so let's do a quick tally of what did people choose to work on of folks who have teams in place. What did you choose to work on using this exercise about your teams? What were the things that were not exactly where you wanted them?
Lynn? Oh, she's coming.
I'll talk since nobody else is. So for our team, we do have regular weekly team meetings. We do regularly go through patients. I think the things that we will work on are one, starting to use data regularly, and we're just getting, or at least learning, how to access reports through e-records, so I'm hoping to do that. And B is we need to figure out a way to include our MA and our receptionists, because we have some location challenges, so the time we meet, they are at a different location. But I think that's going to be really important.
Thank you, Lynn.
So how many folks who have team meetings have medical assistants as part of them?
Ooh, a tiny amount. like 7.
Okay.
Yeah.
How many folks who do not have medical assistants as part of them chose to work on that?
About half of the small amount that didn't have them.
Okay. And receptionists, same questions. Who has it? Same group.
It's a little different group, but same number, same percentage, about 10% of the room.
And who chose to work on that of the folks that don't have it?
5.
I can't. Yeah. Okay, great. Really,
yeah, because they're not on the video, so I'm trying to count.
No, that's so helpful. Thank you. All right, so let's talk about that for a little bit. What questions? What are the barriers to getting medical assistants and receptionists to the meetings? Let's just talk about that. There's lots of barriers. We'll have lots to talk about.
So one Lynn mentioned was scheduling and time and location. What else, Lynn?
The other one I was going to say for us is getting especially our receptionists to be active participants. I can get them to come to meetings, but I have a hard time getting them to be active participants.
Getting them to be active participants, engagement, when they attend is a challenge.
Okay, let's take that one. Nitzali, tips.
Yeah, one thing that worked for us is that one team was made together, only one team. It was just me and Dr. Meisinger, and we started doing the work together. I started talking about it a lot within the group of the medical assistants. They started seeing me do the work in between patient visits. I started sharing the difference that I was feeling and the difference that I was seeing in with patients. And me and Dr. Meisinger started celebrating of how our numbers were improving so much that they kind of got a little jealous about it. And so they wanted to be part of it. They wanted to make the difference too. They wanted to feel the same way. So we were kind of the trial team.
And you know what? This is great. This reminds me. We actually posted everyone's numbers so that it was pretty. And because there's a single person assigned to every task or every area of responsibility, it was pretty clear who was who without saying it. You know, it just said hemoglobin A1C, and it had all of the teams listed, and you know, and that actually was one of the things that really got people motivated. And then once they got competitive actually and wanted to best one another, they were forced to interact. Right. That was we used to have, and it's just little pieces of paper. I mean, it's not fancy. This is printouts from the computer or handmade graphs in the lunchroom. So that's one thing. The other important thing about meetings is who is running the meeting. So I do not recommend that providers ever run a meeting. You could maybe let an NP or a PA run a meeting, but for heaven's sake, don't ever let an MD run a meeting because they shut everybody down. So if you have nurses and medical assistants required to run the meeting, they have to interact. They're running the meeting, right?
And plus, that's pushing them to do the work and to have it done before the meeting time. For example, I was taking care of all the diabetes patients for Dr. Meisinger. I was getting that list ready and a goal before I even went into that conference room to meet with them, so I could tell them exactly what I did, who I got in touch with, how they're doing with the A1C, and so we can plan for future stuff.
And we were reflecting while you guys were doing your exercise that, you know, there are a couple of medical assistants that honestly none of us ever thought were going to be absolute superstars, and there's a couple of them that have never really not left, that actually predate Nitzali and are absolutely the highest performers now. And there is absolutely no way you would have said back in 2002 that these two were going to be your rock stars for outreach. It still sort of shocks me that they're that good. But they have really taken this on in a way, and it's partly because we really pushed them. So professionalizing the role of the medical assistant and the receptionist, making them responsible for human lives, making them understand how important they are, those are really good strategies to get people to engage. I think right now, if your journey is anything like ours, they're sitting back and waiting to see if this goes away. and they're not sure that this is actually their work. They think it's just a fad and that it's actually going to wind up going back to being the doctor's work, maybe the nurse's work, but if they keep their head down, they can avoid the whole thing. That's my guess. That's, I think, what we saw.
Another big one that I noticed too is the when leadership and doctors and providers share the improvement of patients because of the work we do. For example, a long time ago, and we keep having these stories of receptionists or even medical assistants saving patients' life because they got them in to get their pap smear done, or they got them in to have a mammogram done, which was one of the receptionists catch her and notify the provider, the medical assistant, and we all got together with this patient, got her to do a mammogram as soon as we could, and you know, it stopped the patient, I guess, had a early onset of breast cancer, and it was catched by a receptionist. You know, and so these kind of stories of how can save patients' life too, that not only the provider or the nurse also, you know, motivates patients to do the work they need to do.
Yeah, that we have an idea once a year. We try and go over what we call everyone's life list. So everybody that every staff member has identified and has had a healthcare interaction that probably saved their life. So folks who have had colon screens, that have shown you know, significant tubular adenomas, folks who, and that was all done by medical assistants, folks who have had abnormal PAPs that hadn't had a PAP, that it could have progressed to cancer, and you can really celebrate those folks when things happen, and that, I think, is another way to get some engagement. So those are, I think, a few things that have worked for us. Talking about schedules is always a bit tough because the devil's in the details with this one, but how many folks among the groups that you have there have teams that where the medical assistant and the provider are together regularly and consistently? You could just raise your hands.
Wow.
And that's
Yeah,
during clinical care.
Yeah, very small amount, about 10%. Yeah, the question is, you mean like one-to-one?
It doesn't have to be one-to-one, but they have to be working together so that they know that when they come in, they're going to be working, right? I'm going to be working with Nitzali when I come in. She may be covering another provider, but I know that we're going to be working together so we can huddle.
Yeah, there was about 10% of the room.
Okay, so that took a lot of time and a lot of effort, and you should be patient with yourselves, but you do have to do that. That's actually very important. We have had providers change their schedules to accommodate staff schedules. That is something that is a conversation I leave to leadership, but that we've had to do that at times. And vice versa. I think staff are used to having to change to accommodate providers, but it was really surprising to staff to have providers change and understand the commitment that we really felt to the team. So that's actually something you want to think about. Providers' lives are noticeably better when they have consistent support. And consistent support starts to read your mind when you're together at least 50% of the time, more like 75. So if you don't have that, you actually don't yet have providers who have seen the benefit of team, and it's harder to get them to engage. Remember, the provider's the bottleneck. The provider is the one we're trying to offload here. So any new workflows should not involve them. It should involve other people, other staff. It's hard to do that if the providers don't have someone that they can count on and trust. It has to be consistent. For providers to step back, staff have to step up, and there's a huge structural component to that is really the responsibility of leadership. Sorry to be very lectury right now, but I don't know that there's a way around that.
Another question?
This concept, it has to be adapted. Each practice is different. Not all practices have names.
Right.
You know, not all practices have all of those parts. So the whole concept can be used, and the consistency and continuity can be done, but it can be done with provider nurse. The nurse being assigned to that one provider, and they have that consistency in that whole.
Right.
But the receptionist and the sometimes it works like that.
Yeah, just talking about the concept.
Provider and the nurse provider is continuity there.
Yeah, absolutely.
Not necessarily an MA or
Right.
just not all the same structure.
Right. Right. So when we talk about consistency of teams, it's not unique to the specific roles you mentioned. It varies and has to be adapted for each practice. Yeah. Another question?
How do you guys handle logistically when one of you goes on vacation?
How do you handle it logistically when one goes on vacation?
So this is an interesting question. So, you know, when medical assistants go on vacation, they have other medical assistants covering their box. If you're going to make someone an essential team member, they can't just disappear. So really, there's no hiccups when someone goes away. We were asked this question yesterday at a different, at a site visit to our site, and it really, you know, again, sometimes these changes, you know, when the joy of doing change, guys, is that eventually it becomes so much part of the air and the water, you forgot how hard it was before you even had it because it was invisible. And I thought, oh, I haven't thought about this in ages, but you can't, everybody signs out. Everyone has to have coverage, and everyone tells the entire clinic who is covering them when, so that you know when you need help, who to go to. These are essential team members now. You can't, there is no going on vacation without having someone cover you. You can, if you need to, design that so that you're not asking a friend, and you can do structures in place the way we do with providers, but you do have to do that. I hope that was the question.
Yes. Yeah. No, you got it.
Does that include providers going on vacation?
Does that include providers going on vacation?
Of course.
Yes.
Unless they want to cover their box from Hawaii or wherever they are. That's fine too.
In other words, usually when the providers go on vacation, they always have a PA in their team. So they either leave their inbox to the other provider that works in the same team or the PA that works in the same team. So those two providers will take care of her inbox. When it comes to nursing, we have this, we attach our in-basket under their name, so they'll be able to cover my box too and take care of anything that needs to be done urgently. When it comes to the medical assistants, the same way. When it comes to the receptionist, they attach to whoever is going to be helping them, and they notify everybody in an email, going on vacation, so-and-so is going to be covering my box, please either send them the message or they'll be taking care of it. So that's the communication we have when we go away.
Yes, Dr.
Yeah, I just wanted to go back to.
Oh, yeah.
Question about the huddle.
Question about the huddle.
Yeah, because one of the barriers we discussed earlier was actually trying to get providers and nurses to huddle together. I'm wondering, how did you work around the morning schedule to make sure providers and nurses can huddle together without having nurses come in early, use overtime? So how did you get the system to support blocking patients? What that process was like, how you got to that point?
Did you catch the question? So it was around coordinating huddles without overtime, blocking schedules. What kind of, how did you work through all of those challenges to having a consistent huddle with the team?
So remember, part of the huddle, and the thank you again to the folks that demonstrated it, is they showed that they know the patients quite well, right? The other thing, though, you could even work a little more even in that excellent huddle is what's called the pre-visit work. So one of the things that I'm not in love with the AMA huddle sheet is that they act like you're going to be writing the huddle on a piece of paper, and then if that patient doesn't show up, all of that work was for nothing. We actually do our pre-visit work in the chart. We do it in a place in Epic called Snapshot, or specialty comments, which is basically a little sticky note area. So what you do is you put the work in there, but it's also a place where it stays. So if the patient unbooks and rebooks, you don't have to do the huddle. You don't have to do the pre-visit work again. It's already done. It's sitting in there. That facilitates the huddle. So our huddles literally take 2 or 3 minutes. They are not a large chunk of time, and you can see the first patient or the first 2 patients and then huddle if people are late or if it's hard to get together. That was actually really well demonstrated. Oh, so-and-so's not here yet, but that's okay. We'll huddle with them when they come in. And the huddle that they demonstrated was perfect in that it was brief. It was like, you guys have already looked at the lists. What are the problems, right? Boom, 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 and then you're done. You can only do that when you've done the pre-visit work, but I think if if you're going to do work, you might want to get credit for it. So we write ours down. We have a structure that is very simple. It has medical assistant, write the work that that person's going to do during that interaction. LPN, Nitzali goes in with Esther, and the two of them divide up looking at every single patient booked and writes whatever vaccines are due. RN, right? Warm handoff is what we're going to start writing for folks with chronic disease that we know are not at goal. And then provider, and the provider then gets bossed around by everybody else and can boss everybody else around. So if I would like to have a GAD7, which is a screen for anxiety done, I write under medical assistant, GAD7, please. If she wants me to get stuff off of her list that's annoying her, and Carla is famous for this, she'll write hepatitis B because I haven't actually resolved that on our list of, health, we call it health maintenance. So I'm just sorry, I'm hesitating to think of a term that makes sense to everybody. I think a defect list, if you want to think of it that way, or the places, opportunities for patients for prevention care that haven't been addressed yet. She loves lists, Carla. She's really good for me. So that kind of pre-visit work is what makes the huddle tiny, tiny, tiny in time. And there are no issues with schedules then. You just have to be flexible about when it happens, but not about whether it happens. There's no flexibility there.
Yeah, that does work so much well to help the workflow for the following day. So as the LPNs, we manage that. We start doing it. We start putting it in every single patient's chart for the day before for those patients coming the following day. Other than, you know, putting in the immunizations that they're due for. We also look at the health maintenance, like she's saying, the list, and we also add down whatever the medical assistant should be doing for the patient even before they're seen by the provider. And that actually does help the workflow so much better, not only for the providers, but also for us, being in case the providers are running late. The medical assistant sees the snapshot, does whatever she needs to do with the patient that we have written down or the provider has written down, and even pages. And we go ahead and give the vaccines, even though, you know, not to waste the patient's time, and also while they wait for the provider, which helps also the workflow. So they don't have to wait for the nurse afterwards for shots or any other things that they're due for.
So here's the list of things that I used to do, right, that you guys did with the M&M exercise. I have not ordered a mammogram in I don't know how long. And I don't even really care what the result is unless it's abnormal. Then I really, really care. I don't think about vaccines. Vaccines are nurses' jobs. It's protocol. It's a workflow. Don't ask my opinion unless it actually matters, right? Always ask the patient's opinion. That always matters. But don't ask my opinion as a doctor if you're not then going to do what I say. And honestly, if I'm giving an opinion that goes against evidence, I don't know that my opinion should matter. They're the best that we can, right? This is a huge cultural shift. So the ability for me not to have a red book, right, for vaccines hanging next to my desk, which I used to have, not to have those little graphs of when are the child vaccines, right, due, not to have to remember that now you only have to give 2 HPVs instead of 3, but it only starts at age what? I can't remember.
Age 9.
Thank you. Right? I kind of absorbed it because Nitzali yelled at me a couple times when I told patients they were getting vaccines and then they weren't, and then they were so happy to see her. But that is the kind of work. The CDC is going to trump my opinion, and they probably should. So allow me to be a doctor, which is actually, it turns out I really like being a doctor. I really like diagnosing and treating. I really like talking to patients, and I really like meaning it when I say to you, how can I help you today? What do you have on your mind? And I used to say it all the time, right? I didn't actually mean it because I had this huge list of things I was worried about. I was kind of half listening. Patients are really smart. Why patients like this much better is that they know I'm really much more present for them when I'm there. And I'm much calmer because I'm not really worried about whether I'm going to give the wrong vaccine. It was very stressful when I was doing that. And it's very difficult to keep up with all of the regulations, but it's really Nitzali's primary job, so naturally she's good at it. So some of the things I think that we're talking about today are provider focused in that the providers have to actually let things go, but you really do have to give them consistency for them to trust that. I am still a doctor. I will not trust you if I don't think you're going to actually do the right thing for a patient that we both care for. I have right? I have a lot of pride in the work we do, and I know that on some level, legally, I'm still ultimately responsible. So having really high functioning teams is the best way to let providers let it go. All right, should we carry on?
Yes.
We're almost done, guys. It gets happy from here. We're done being preachy. All right, let's go.
All right. So in order for us to be able to keep working as a team and keep on getting to know each other better, we came up with, we did a little survey a couple of years ago, me and another medical assistant, where once we started working as a team and we started outreaching to all these patients and doing all this extra work, we wanted to see, how people were feeling, every single different staff, how were they feeling about having all this extra work to do, and how were they doing it. So we did a little survey to see how they were feeling about it, and it actually, seeing the changes and seeing the improvement in patient care, actually was making it really, they were really happy about it. Happy just because they saw the difference in patients, they saw difference in the environment, in the flow. People were getting along better with each other. And so, after the survey results came out so good, we just started doing fun things too, including fun things. Like, we mentioned earlier the retreat where we get together and do fun stuff together. I'm the party person of the clinic, so what I do is I planned a social outing at least once a month. We call it a mixer, where we get together somewhere after work, usually Fridays, and we socialize outside of work. And let me tell you, we do learn about each other so much more. It's amazing, and it actually has improved, how we get along in the clinic too. So we love to do that. We do pool parties, the retreat. Next slide, Luz. It has helped our engagement, I say. And this is the rainbow and the butterflies. After doing all of these fun things and working so hard and seeing all the patient, the difference in patient care and seeing the improvement, we feel like we're in heaven. But that doesn't mean that changes doesn't still happen though. But I guess we're so used to the changes and implementing workflows and changes here and changes there that we just go with whatever comes. And next slide, Luz. And this is what we think about team. Together, everyone achieves magic. And that's really what we've seen from the before and after. Magic does happen. Seeing all the happiness, and not everything is happy, because of course there's still the extra work and changes still happening, but we learn how to be patient, and because being patient, giving it time, pushing ourselves, motivate ourselves, but especially working together is where it's really going to keep us going, and seeing our patients happy and caring for them is what we're there for. Next slide, Luz. See, when we get happy news, our face becomes as the baby's face. We celebrate. And again, I think, one of the biggest things is leadership being involved and letting us be involved in everything. The initiatives, the implementing, how is it working, letting us engage, no matter what our title is, has made major success in what we have come to be doing, and it's great.
And our turnover is low, and we were joking again, even the folks that we actually thought we wanted to get rid of, they just don't go,
Yes.
And actually it's really good they didn't, because it turns out they're some of our highest performers now. It really just was not a great fit for them initially, and this is a much better fit, but it's been a joy to actually see that. Ultimately, I felt like I could just retire when I saw the answer to the bottom question. I'm treated with respect every day by everyone that works in this practice, and when it hit 100%, I thought, okay, I can go home now. right? I'm going to move to Hawaii. I'm going to Hawaii. I've actually never been to Hawaii. I hear it's incredible. So it's pretty fast once you really do show folks that you mean it, and that when they have an idea and you take it seriously, people see that very quickly. I do like the post things, the competition, they take care of it themselves. It was really kind of fun. Maria used to get really competitive, remember that? She was nuts.
Yep.
You guys have identified most of these actually, right? So vacations, sick days, right? Clear communications. How do you get people to step up and own the work? So if we haven't done a good job addressing all of those, let me know right now. Appropriate prospective staffing, try and fill in the gaps. I feel like we work with duct tape and twine. We never have any backfill, which is really hard. Just apologize and try and everyone sort of steps up. There's personality management with teams, right? Personality really matters if you're going to be working so carefully with each other. We've had some really interesting, fun ways of addressing that. You can have everyone take those little personality surveys. They actually have them online that show you whether you're an introvert or an extrovert, intuitive or thinking, and and you can actually then sit down with your team and go over who everybody is, because it really does help people to understand why they might be reacting a way that you might not resonate with or understand. So I'm happy to answer questions about that. But there's also psychologists are really good at this stuff. So if you have any that you interact with, they can give you really good advice. And there's a ton of stuff in the literature on how to work well in teams and how to manage personalities. Only thing that really matters is that we're taking better care of patients, right? That is actually why we get out of bed every morning. And almost immediately we saw incredible clinical results, and we've been able to maintain those now since about 2008. And that has been incredibly gratifying. So these are some of our earliest results, and I keep them in because I know that some of you guys are in early days, but this is what we saw. And I actually got a little depressed because I felt like these were people that needed so little help, and they just did amazingly well. And why hadn't we done this before then? But I've had therapy and gotten over it, and you should just do this because it feels really good really quickly. And I think, as Nitzali pointed out really astutely, celebrate the success, get the staff to engage by having them understand that they really are important, they matter, and that they're going to make a difference to people when they show up to work every day. It's not a paycheck. More awesome results. Next slide. And this is one of my favorite quotes for the transition. I think I have other favorite quotes now, but this was really meaningful to me. I think a lot of us as providers go into this because we really do love our patients. And I think there's some suspicion that we're the only ones that love our patients, and that's really not true. Staff have for a very long time been caring for them sort of quietly and behind their backs because we haven't let them come out into the light and really flourish as caretakers. And teams work when your whole team loves the patient as much as you do. This is a transitional quote. Now it seems like ancient history to think about this now, but that is where I really came from. And I learned more from my patients and the team in this process than I think in any other part of my life. So with that, we'd like to thank you very much. You've been incredibly gracious putting up with our little faces in my kitchen. And I'm very sorry I didn't get to meet each and every one of you. It would have been really fun, but maybe next time.
Awesome. So Bill's going to come up and do a wrap up.
Anybody?
Yeah.
Well, I just want to thank everyone again for stepping up and helping out today, putting this on. Brenda, Luz, Darlene, Lisa, Sue, Carolyn, who left, Deb, who left. They have both vacations planned, and they're on their way to the airport, so hopefully they'll get to where they need to go. And I want to thank you also for helping out today and putting this on for us, even though it wasn't exactly how we intended. We definitely have to get you to Rochester sometime. We have some great things here in Rochester. We'd love to show you the area if you haven't been here. We have a great wine industry, craft beer industry. We have these incredible things called garbage plates, which we'll have to look up, which we could introduce you to. So when you come next time, plan on coming the night before so we can take you out.
We will.
All right. And thank again to Luz for facilitating today and making this work and using her phone as the hotspot to make this happen. And most importantly, thank you to all of you for coming And hopefully we can put on more of these types of events for you in the future. Please let us know what ideas you have for things you'd like to hear about. The discussion today generated some things for us to think about. In particular, the whole idea of how can we take a look at some of those rules, whether written or unwritten, that prevent us from really using our teams effectively. And how can we influence that through some workforce development in our community and really maximize the team. And going back to the quote that we opened up with today, really use them to play that symphony as an orchestra instead of trying to whistle it on our own. So thank you again for coming, and have a safe trip back to wherever you're going. Oh, last thing, surveys. I think a reminder of that. If you want the CMEs, please turn in your surveys.